I think this is something that you might want to pay attention to because it's something you can take back with you. As Brent said, CEOs, the chief executives of healthcare organizations are really reeling with the rollout of this particular measurement and metric. And they're looking for solutions. This is frightening to them. You know, I did a version of this for the American College of Healthcare Executives last October, and while we were doing the program, between day 1 and day 2, some word came out that CMS had made a mistake in their predictions for what these penalties would look like. Anybody remember this? All I can tell you is when I went into the room the next day, most of my audience who were chief executives looked pale and sweaty, and I thought I should have an EMS team ready to run them to the ER because they were very stressed out by this. Some of the numbers, like Barnes Jewish in St. Louis was expecting now a $2.6 million penalty just the first year just for readmissions. So this has them anxious, and I agree with Brent. I think the ER can play a role in it. So if you will listen to me for about 25 minutes, you will leave here probably knowing as much or more than most people at your organization about the problem and some of the solutions. And I'm going to sort of spin off of what some of the other speakers have said. And in the last 5 minutes, let's sort of brainstorm about how could the ER play into this? Like, let's just get wild and crazy. How could the ER, maybe help solve this problem? I can tell you if you're having issues with your leadership, he will suddenly be your friend if you make an appointment and say, I want to talk to you about readmissions and how the ER can help. You will have a new best friend, and you might be able to get some of the things you've always wanted for your ER. So a little background information, what we know and what we need to know. And I guess one of the things that bothers me most about this moving forward is, unlike other measures that we've had to address and subsequently pay penalties for, I don't feel like the evidence base is there to tell me exactly how to fix this, Well, look, we all got on board with AMI, right, doing STEMIs, even the pneumonia core measures. As things have rolled along, in the ER, we're willing to play, we're willing to get on board, but this is a completely different issue. Without a very good foundation, our feet are being held to the fire as healthcare providers to fix something that really requires, in my view, system fixes that are broader than even just the healthcare organization. They're community fixes. So what we know and what we need to know, what are some of the strategies being employed, and some success stories. Email me if you would like a very nice, easily readable paper about solving the readmissions problem. There's one that came out from the California Healthcare Foundation, and it's just a very nice, easy read, couple paragraphs. It has a lot of the things that I mentioned in here, talking to you about what's being tried around the country, and if you want that, I'd be happy to send it to you. So we know that probably more than anything, readmissions show us how our healthcare system is failing, how as wildly as expensive as it is, we fall down. It also shows us that we don't have very good disease management, because if we had good disease management programs in communities, this would help us with the readmission problem. And it just points to overall the serious gaps that we have. Everyone cares. You heard yesterday that by 90 days, 30%, almost a third of the people that are in the hospital now will be readmitted. Right now, think about this, this is stunning. Of the people in your hospital right now, right this minute, within 30 days, 20% of them will be back. We really can't claim this as a success, can we? On any front. And it points to a lot of the problems in our overall system. And it's going to force us to be more accountable. Right now, as you've heard, we're all practicing in our little silos. Fee-for-service has not only allowed but encouraged us to go about it that way. And you see, when people are being discharged, the provider who care for them wants to know more with them, especially if it's a subspecialist, right? Toodles, and out they go into thin air most of the time. And as we get older, we're going to see more and more of these patients that have multiple chronic diseases that need sort of co-management and co-team management. Here's sort of an interesting paradox, So in the last 20 years, as length of stay has gone down, anyone remember, I remember when I was in medical school, how long did an MI stay in the hospital, a fresh MI? 2 weeks? 2 weeks? So we've seen length of stay go down, mortality rates have also decreased, but readmissions have gone up. So this is a suggestion that we're failing on this front. Dartmouth Atlas Health Data, you're all familiar with it. They've been tracking Medicare data for more than 20 years and showing us the extreme variation. And this is really fascinating. The very pale green, ooh, it's cheap to take care of you. And the very dark green, we're spending lots of money on your you-know-what. And so because the variation is extreme. Well, there's also lots of variation in readmission. But the one thing that we can say is readmission rates coming back in within 30 days is continuing to go up no matter what region you're in, no matter where you are. And this is just giving you some idea of what the numbers are. So Aurora, Illinois, 14.3%, now up to 18%. That was in 5 years, just steadily marching up. University of Minnesota, those guys in Minnesota know what they're doing apparently. They had 19.2, I'm saying it tongue-in-cheek, 19.6 up to 22.2. So everybody's is going up, and that gives you an idea of what the numbers look like. This is showing, if you look at the yellow bar, that the percent that gets readmitted within 30 days, and then the percent of healthcare admission dollars that goes to them. So it's a little bit disproportionate, isn't it? 18% of patients get readmitted, but that counts for more than a third of all of admissions in terms of dollars. And it's going to go up, as Brent said. It's going to go up. It's starting at 1%, 2%, 3%. And this is going to be a significant penalty, especially when you marry it with so many of the other penalties that are rolling out concurrently. So what do we know, and what do we need to know? 30,000-foot view. The fragmented system helps to contribute to this. The fact that we have such pressures on primary care, which are only going to get worse. Lack of incentives for the appropriate care, because no one ever incentivized you to keep them out before, did they, right? If you're a doctor. The money came from when they got sick and came in. And so we have a whole system predicated on rescue, don't we? Very little predicated on prevention and keeping people out. And then also, I believe that we have let patients get off scot-free. In my view. There's not a whole lot of penalties for patients when they don't do what they're supposed to do, and I really want them to have some skin in the game. In particular, so many of the chronic diseases are going to have a behavioral component, right? Substance abuse, obesity, lack of exercise, smoking, there's a behavioral component, and they've got to get in the game too, and they haven't really been asked to play. So all of these things help to contribute, and like I say, my husband always say, follow the money, and the money has encouraged us for the behaviors that we've had so far, which have not been, global view of the patient in an effort to keep them well and keep them out of the hospital. These are the big gaps, and believe it or not, the reasons that people get sick again are really very simple, and the ways that we can help them to stay out of the hospital and do better are also low-tech, not particularly expensive, and fairly easy to do, but you know what? We do not have any infrastructure to do this right now. So patients are very confused about their prescriptions and their instructions. That's why some of the solutions are to have a pharmacist do the discharge and go over medications with patients, making sure they understand. They often don't know who to call, especially if they don't have a regular provider. They can't get an appointment. They don't know how to recognize. Isn't this obscene? You've been in the hospital for 5 days, and when you go home, you don't know what signs and symptoms to watch for that say you're getting sick again. But this is true. They really do go home completely, in large part, unaware. This contributes to them coming back. They don't know if they're getting worse. And so you see some of the strategies that are being employed are intensive training to, of the patients and their families, what means you're getting worse. When do you have to be seen real quick right again by your doctor so you don't get worse? So all those gaps just lead to this downward spiral, which leads to ED visits and then readmission and adverse events and outcomes sometimes. Interesting little trends and factoids, because it's the numbers crowd again. High readmission rates for one disease correlate with high readmission rates for another, in others. 42% of patients discharged had a follow-up appointment in 2 weeks. In my view, 2 weeks, it's already starting to unravel if it's going to. And I think this is really rather shameful. So sidebar, how could the ER get in the game with this? Do we have anything to offer patients who are being discharged who can't get in to see anybody? How about you go home and you talk to your C-suites about having a follow-up clinic in the ER your quiet hours, which would be 7 to 9 in the morning. Well, they'd really be from 2 to 5 in the morning, but they're not going to show up then. But could you book some early morning appointments to do follow-ups for somebody that just couldn't get in anywhere? Why not? Why couldn't we help out with that? Or alternatively, if you have a freestanding clinic or an ambulatory care center affiliated with you, could they follow up there? Could we provide that service? As people have pointed out, we are there 24/7. Why couldn't we get in the game here to try to help with this problem? I think there's no reason. I think we are limited by our lack of imagination for what an ER doc could do and could be. And high readmission rates correlate with very high ED utilization. Again, I think that points to the problem that they can't find anyone to see them. Look at the variation too. So if you live in New York City, only 20% had a follow-up appointment at 2 weeks. So it's not looking too good for you. Maybe you want to move to Lincoln, Nebraska. It gets a little better, at least. 61.4% could get an appointment with a primary care doctor for follow-up. And doesn't that seem sort of logical? Somebody's been sick enough to have to be in the hospital. And boy, it takes a lot to get hospitalized these days, don't you think? I mean, you have to be really sick to get, I said, what does it take to get a room here anymore when I'm fighting with 5 consultants and nobody wants to admit the patient? So you have to be very sick to get in, and then we just discharge you to thin air, and we cannot find a way to get you an appointment in 2 weeks? So then how should we look at this data? Remember I said, other things that have come my way that I've been asked to play ball with, there's been a body of evidence that was irrefutable, and they tell me what I'm supposed to do. Here, there's really a positive data, but somehow I'm supposed to fix this because guess what? They're in the ER. And if you don't think that you're going to start to feel this, as the hospitals get squeezed, so will you in the ER. They're going to come down, sure, you can't keep admitting these people that are, you got to find another way. You got to help us. You got to work with us. We are going to be in this whether we intended to or not, and whether it's our problem or not. But we don't know, how should we be looking at it? Should it be all cause, just anybody who goes out? So it would be you're the MI who falls and now they break their hip and they come back. I'm not sure, is there anything you could even do about that? So should it be all cause because they're all there's a move afoot that they be treated that way? Should we define certain groups and study it that way? Should we look at certain diseases and look at it that way? There's a lot of talk about, we'll risk stratify people and we'll throw resources at the ones that we know are going to come back. You'll see that that's not really panning out either. So in terms of risk prediction models, there's a very nice review in JAMA in 2011, and the authors did a systematic review of all the different ways that people were trying to risk stratify people as they're leaving the hospital to say, this guy's going to come back, let's give him resources, let's send somebody to his house, and so forth. And what they basically came down, the bottom line at the end of this review was, none of them are working very good. So you might as well just roll the dice, because this guy, you're looking at his back now, he may be back within 30 days. So I believe that ultimately we will get there, but today, when I'm trying to fix this problem or look at solutions, I can't put my eggs in the risk prediction models bag. Now, you stay with me for at least these few slides, because I just think you'll think it's fascinating. You'll see what I mean, like, what are we supposed to do with this information? Where do we go? So Kangovy did this article also in October 2011 in JAMA that I'm not sure people saw it, because if you saw it, you'd have to be still scratching your head. So low level of access leads to high readmission rates. I can kind of get that. Can you get that? So they go out, they have lack of resources, there's nobody that'll see them and follow up, and they can't get timely care, so they come to the ER and they get readmitted again. Can you buy that? Okay, all right, I'm there, I understand that. So what we got to do is we've got to give these guys the resources. Low level of access leads to high readmission risk. Well, wait a minute. And this was looking at a number of studies to break this down. And so what have we done here? The theory is a couple of things. We've got pent-up demand. This person who didn't get any health care for 25 years now knows how they can get it. Probably they go to the ER. Maybe they've got a doctor, but the point is now they understand how to get in the door, and so they're doing it. Or maybe we provide so many services and so forth that we pick up things that had been missed, and so now they're back in our system again. So, okay, I feel like I'm saying the exact same thing backwards, and I'm supposed to swallow it, but okay. Okay, then how about this? Low level of access leads to low readmission risk, because there have been some studies that have shown this. And apparently, at least what the authors will say, is that you have to have a minimum level of access to patient care. So basically, if you want the guy with no resources to go home and not come back, make sure he has access to no phone. Because that's what they said, when they have absolutely no basic resources at all, they can't even call 911, and so they don't come back. And so I'm totally baffled, but clearly you would have to believe that these are more than just doctor or department or practice or hospital problems. They really go back to community issues as well, right? The least among us can sometimes show up a lot and sometimes not show up because they just can't get there. So to me, it's a very perplexing story. And as I said, it makes me wonder, like, well, where can I find in all this my solutions when it's this confusing? Well, that said, we're going to have to. It is believed that about half of readmissions are preventable. And we know that prevention strategies are inexpensive. We can say those two things. The definition of an avoidable readmission related to previous hospitalization, not expected as part of a plan, and occurring within 30 days. I say fair enough, but they're saying that they believe that half of these don't have to occur if we've got some strategies in place. Big cause is that the patients just are not getting it. And we in the ER, we deal with a lot of folks with varying, mental resources. So we sort of get this, don't we? There are clearly people that are going to leave and just are not understanding what they're supposed to do, when they're supposed to come back, and so forth. And these are the folks that we likely want to put some resources into. Also, when there's not coordination with the primary care team, can't get that appointment, and the medication issue is huge. And how many times have you seen this? I know you have all seen this if you're still doing clinical work. The patient just got out of the hospital and they didn't understand their meds, and either they're like taking all of the blood pressure medicines, not the ones they were supposed to not take, and the new ones, or they're not taking any of them, or, right, we all see this, and this leads them to have a terrible outcome. The other thing that we don't do very well is clarifying what they want at that home stretch. Did you know this? Have you heard this number? 75 cents of every American healthcare dollar is spent on the last 6 months of life. Anybody think that's like a really good plan? It clearly shows it is a rescue medicine plan when all of our resources are going into futile care at the end. So avoiding readmissions, at least we could say this, if we could develop for each patient an approach that takes into account their level of understanding, sophistication, resources, and so forth, and sort of keep track of them, because you really have to agree, when people go home now, it is often the sense that they're leaving the hospital to go into thin air. Even if we've just spent $250,000 saving them, now they go out and there's just nobody picking it up from there. And if you can think about a different model, it won't just be telephone call or an appointment. It could be, you could text them, you could have a Skype appointment or telemedicine appointment with them. You could send someone to their house. Like, I love the idea of community paramedics checking out people. The idea being that you want to have your resources going to the people that are going to have the most trouble. In many places still, the discharge process is a little bit willy-nilly, and we don't pay attention to the really important elements that have to take place. And so the solutions are winding up being very low tech. It is, having a process that's articulated, having a team, preparing for the discharge, instead of, in many places it still is, a nurse comes in and says, get dressed, here's your paperwork, you're going home, without a lot of ado. Don't you think that's true? I know that's true in very many hospitals. And so making sure that it's a little bit better planned, it's orchestrated, they have an appointment in their hand when they leave, and we start the whole process at the beginning. These are all of the elements that make it work better. And like I say, this is another argument in my view. So remember, I don't want them to come back if they've been admitted, that readmission, but I don't want them to come back if I've done a lot for them in the ER. I'd like them to hold on to the gains that we've made in the ER. And so it's another case for the pharmacist there to make sure when the patient leaves, do they really understand what those medicines are and what they're supposed to do. And so people are doing things like sending someone out to visit the home, home visits, calls, a combination of these things. So basically, there's stuff that's supposed to happen when they go home to make sure that they hold on to their wellness. Here, I want to show you. So BOOST is a hospitalist sort of initiative, better outcomes for older adults through safe transitions. And they basically advocate this team approach to try to prevent the readmissions. Project RED, have you heard about this from NQF? And I don't want to go through the the whole details, but I did put them in your handout because I wanted you to have them. It's basically just a system for discharges. There's 12 components, and they guarantee, if they can guarantee this, that you can have a 30% reduction in your readmissions and save about over $400 a patient if you will do these 12 things. And it's pretty straightforward, folks. Cookbook, here's your recipe for safe discharges, the 12 things. And the reason why everyone's paying attention, we've got financial penalties we mentioned. It's also being posted on hospitalcompare.com along with all of your other data. So you really are going to care about this, and they're using the money to change behaviors. But as I say, to me it's a little bit less clear what I'm supposed to do. I'll do it, but can anybody tell me what exactly it is I'm supposed to do, especially where it's going to come home to roost in the ER? So some success stories, and these are most of them are from that paper from the California Healthcare Foundation that I'd be happy to share with you, very easy read. This one, they spent a lot of time educating patients on the red flags, how to know that they're getting worse, and they had both a home health visit, a visit before they left the hospital, a home health visit, a follow-up call, and a coach to contact them. And they saw that they reduced their 60-day readmissions by 50%, so that's pretty good. The red will always tell you the sort of success. The Visiting Nurse Service of New York, theirs was doing home health, and someone said, I see a huge opportunity for home health. So do I. You know, especially for people where it's difficult for them to get a follow-up visit, let's send the care to them to check them. And you look at what their outcome measure was, reduced calls to 911. That works for me, right? We said, what happens to them when they fall apart? They call 911 and go to the ER. So to me, that's a fine metric to use. Boston Medical Center used the RED program that I showed you. And they got their follow-up visit appointments up from 30% to 94%. Bravo, right? Remember, we said the key to that is them having follow-up, and they reduced their readmissions. And these are all, you'll see similar themes. It's around patient education, follow-ups, follow-up visits and phone calls, home health coaches. They're not very expensive, are they? In summary, the solutions are low-tech. They may be population dependent. You're going to approach a patient who's pretty sophisticated and has lots of resources, slightly different than you will the person at the other end of the spectrum. But the key is managing the transition so that that patient doesn't go out into thin air. So let's kick this around. What else? Anybody else think of how else could the ER be in this game, do you think? Like we said yesterday, using observation instead of admitting people, right? So I feel like you go home and have another look at your OBS unit. Should that be built out a little bit? Should you expand observation services, and be in the game? Because I think that's a big solution. A lot of times what you're going to need is more time sending somebody home, right? Or how about this? What if you could have a patient who's in the ER that you kind of want to admit because it doesn't feel like that follow-up thing is completely in place? What if you could send them to your urgent care, your low acuity center, or your ER first thing in the morning during the quiet hours for that follow-up again? Why not? Anybody else got some thoughts? How could we play this game? See, I think we are uniquely positioned to get in this and be part of this, be part of the solutions. What about anybody got a call center at their hospital? Do you do like Ask a Nurse or something like that? And these are woefully underutilized, right? Especially there are very many places where they have someone sitting there 24 hours a day and they get very few calls. So how about this? What if the call center could call out, not just take calls in? What if the call center got a list of people that were discharged today and called them tomorrow to see how they're doing? Like I say, aren't there a lot of ways? Could the ER totally jump in the game? Could you have, most of you probably have a follow-up nurse, it's a new role. Do you have at least a part-time follow-up nurse? Someone that's dedicated, not doing clinical work, but they're going to call on your cultures or your x-ray discrepancies. Do you have somebody like that? It's a growing position. What about if she also calls on patients who have just been discharged to see how they're doing? I really believe we have resources that are just sitting there and that we could be part of the solution. And that we've not looked at it. Not to mention places where hospitalists and ER could act like the relatives that we are. We're dang cousins, for crying out loud, and could develop programs together. Jim, come down and see this patient. I won't admit him, but will you arrange some follow-up for me? Or can you guys get him into one of your clinics tomorrow, and we'll work on this together? Don't you see? I think there's all kinds of possibilities here where we could have, like I say, this joint participation with us and hospitalists, the relatives that we are, kissing cousins, or, you know, cousins with shotguns, as it were. But there's that possibility. And then all of our other resources that sit there, I believe that we could play a part in the readmissions problem by offering some solutions. Anybody else got any other thoughts? Yeah.
Who would pay for this? Would the hospital pay for these kinds of services that we could run, or, for example, this clinic
Mm-hmm.
idea of, you know, we have a terrible problem getting patients in. A lot of them are uninsured or Medicare, which is Medicaid. You know, who would pay for this? Would the hospital pay for this?
So I see it running, the question is, how would you
Yes.
pay for some of these things, like a follow-up clinic? I see it running the range from getting a community health grant to treating them like any other unfunded patient, because no matter what, I mean, so you had somebody come back to the ER the next day for a recheck because you didn't want to admit them, they're still going to be cheaper than a readmission with penalties, right? So, I mean, we're sort of looking at that global picture. And also remember that someday it's going to look completely different. It's going to be paid in bundled payments and by episodes of care, in which case we're just in it like everybody else, providing worthwhile service instead of, you know, nitpicking it. But a good question, I grant you. Maybe some of my ideas are too idealistic, but remember, we need some of us around, right? A few idealists in the room. Any other thoughts or ideas? There's some smart people in the room. For instance, I was talking to some people, big national health care staffing group that staffs both urgent cares, ERs, they have their own call centers, and they have some hospitalists as well. And I said to them, you guys got it covered. They've got every element, don't they? They could be going around offering solutions to readmissions because they got the whole show, you know? Yeah. So you're talking about, and actually, so you're absolutely right. You know, in Utah, we have a very old but healthy old population. They still get frail, right? Because you know, Utahns, I'm a Catholic girl in Utah, transplanted, but the Mormons don't drink, don't smoke, and they live to be way old. And they want to go home, but they're frail, and you're seeing before you, you know, the potential for a readmission. You know, we have some, you know, SNFs, we have some intermediate places. We're very big on assisted living arrangements that can be temporary. So we sort of wheel and deal it and slice it, dice it a number of different ways. But I'll tell you what, the hospitalists must be doing something right, because our hospitalists now have a 30-day readmission rate of 5.4%. And part of it is because no one leaves until there's an appointment, and the, you know, family and patient can repeat back when that appointment is, where that is. They do little teach backs and quizzes on the medications before they go. So I greatly admire my hospitalist group, even if like sometimes we're kissing cousins, sometimes we got the shotguns out. But I love my hospitalist group. I think they do a really good job at this element. Yeah.
Do you have any unintended consequence of extended length of stay related to that?
You're talking about when you don't let them go because you're trying to arrange things. Well, see, now here's what I haven't learned. I need to sit down and talk with them more. They actually do very well on their hospital inpatient length of stay. So, but you know, I have to say this about my system. Intermountain has been using information technology to support the work of clinicians for 30 years, so they're ahead on so many things. They're constantly pushing information to you, prompts and reminders. The ER, I don't feel like we have a system as good as some other places in the healthcare organization, but they have a lot of things like that that really help. And they were seeing case management as a necessary part of this whole thing, you know, 20 years ago. We have one of the oldest case management programs too.
All right, why don't we break for lunch? Let's come back in 1 hour, if that'd be okay.
Yes.